Welcome to this clinical walkthrough on the essential tremor case for the UKMLA, brought to you by Mediate, your 24/7 practice partner. Let's get right into this OSCE station so you know exactly how to ace it. All right, let's set the scene. You're in a GP surgery and you're the FY2 doctor. Your patient is a man between 50 and 60 years old who's come in because his hands are shaking. Your mission is simple. Take a focused history, do a relevant examination, and then create a safe management plan. First things first, how you start the consultation is critical in an OSCE. A good introduction and getting clear consent sets the tone for everything that follows. Here's your opening line. It's clear, it's empathetic, you state who you are, you show you know why they're here, you say what you want to do, and you ask for permission. This builds rapport instantly and shows the examiner you're a respectful doctor. Now for the history. The only way to score top marks and make sure you don't miss anything is to use a framework. It keeps you structured and on track. For the main complaint, the tremor, your best friend is the ODI-PARA framework. It walks you through all the important characteristics, one by one. Let's look at the specific questions you need to be asking. These questions are absolute gold. Essential tremor is an action tremor, so you need to ask when it's at its worst. Is it when they're writing, drinking a coffee? And what about relieving factors? The classic story is that a small amount of alcohol makes it better, while stress or caffeine makes it worse. And of course, it should be gone completely at rest. Before you even think about settling on a diagnosis, you have to screen for the serious stuff. This is how you show the examiner you're a safe doctor. You need to ask direct questions to rule out each of these red flags. Being specific is everything here. Don't just ask any other symptoms. To rule out Parkinson's, you have to ask about its main features: rigidity, slowness, and balance issues. Using precise language like this shows off your clinical knowledge. So once you've explored the tremor and the red flags, you need to finish the full history. That means covering past medical issues, medications, allergies, social life, the whole lot. But the one to pay special attention to here is family history. Essential tremor runs in families, so if they say their mom or dad had it, that's a huge clue. And to wrap up your history, always address the patient's perspective. Use ICE. What are their ideas about what's going on? What are their biggest concerns? And what are their expectations for today? You can bet most will be worried about Parkinson's, and asking about it shows you're practicing patient-centered care. You can practice this exact case right now. Get objective feedback on mymadid.com. Honestly, repetition is what makes these stations second nature.
Okay, history done. Time to move on to the physical exam. This is where you get to confirm all those suspicions you've built up from the history.
And just like with the history, you must get clear consent before you lay a hand on the patient. Tell them what you're doing, tell them it won't hurt, and confirm they're happy for you to go ahead.
Here's your game plan for the focused exam. Follow these steps in order. You'll start by just looking, then do specific tests for the tremor, check their muscle tone, and finally tell the examiner how you'd finish the full assessment.
First up, inspection. Look at the patient's hands while they're resting on their lap. There shouldn't be any tremor. Then ask them to stretch their arms straight out in front of them. This is when you'll see it, that classic fine two-sided postural tremor. That's the hallmark of essential tremor. The spiral drawing test is a brilliant diagnostic tool. Ask the patient to draw a spiral. With essential tremor, the spiral will look shaky and irregular, but, and this is the key, the size of it stays the same. This is a night and day difference from Parkinson's, where you get micrographia, meaning the spiral gets smaller and smaller as they draw. Next, you've got to check their muscle tone. Ask the patient to relax their arm completely, then gently move it at the elbow and the wrist. You're feeling for any stiffness or rigidity. In essential tremor, the tone should be normal. No lead pipe or cogwheel rigidity helps you rule out Parkinsonism. You won't have time to do a full neuro exam, so you have to verbalize it. Use this exact phrase. It tells the examiner you know what a complete assessment involves and that you're a thorough, safe clinician. So, you've gathered your information from the history and the exam. Now it's time to put it all together, give a provisional diagnosis, and talk through a management plan with the patient. Explain your diagnosis in simple terms, no jargon. The most important thing you can do here is to say clearly that this is not Parkinson's disease. This is what they're worried about, and you need to address that fear head on. From a GP setting, your management plan needs to be safe. That means referring to neurology for confirmation and specialist inputs.
You can mention that there are treatments available like propranolol or topiramate, but you must be clear that it's the specialist who will decide on and start these.
And that's how you nail the essential tremor station. It's all about structure, clear communication, and proving you're a safe pair of hands. You can practice this exact case now on mymediate.com.